Hello, this recording will go over epiglottitis. So itis on the end of the word there, you know that means inflammation, infection. And in this instance, we're talking about inflammation or infection of the epiglottis. So a quick review, what is the epiglottis? Do you remember that one? It is the little flap of cartilage that covers the trachea or the windpipe when the patient is swallowing in order to prevent aspiration. So just understanding the definition of epiglottitis, what do you think the big problem is going to be for this patient? They got a condition where they're going to have inflammation of the flap, the epiglottis, that covers the trachea or the windpipe, right? So the big concern is going to be that inflammation is going to cause an occlusion of the trachea and not allow air to pass. This could be a big emergency for your patient. So pathophysiology, what is going on? Acute inflammation and swelling of the epiglottis and surrounding tissue. It's considered life-threatening with it's a rapidly progressive condition that can cause complete airway obstruction. The big thing about this is it comes on pretty suddenly. So the kid goes to bed feeling fine and wakes up with a sore throat and difficulty swallowing. Etiology, what's causing it? It's almost always caused by the bacteria H. influenzae, and there is a vaccine, the Hib vaccine can help prevent that infection of that bacteria. For our purposes, we just want to recognize that it is a bacterial infection because that helps us recognize what types of interventions are going to be appropriate, right? For croup, which the majority of the time is viral, we're not going to see antibiotics brought on board for croup. For epiglottitis, which has a bacterial origin, we will see antibiotics used for the treatment. All right, assessment, noticing, recognizing cues. What are we going to see with our signs and symptoms? Again, abrupt onset with rapid progression, severe sore throat, difficulty swallowing, high fever. They're going to appear very ill, anxious, frightened, irritable, lethargic. Anytime there's concern with airway not being patent and having problems breathing, that anxiety can come about, the feeling of doom can come about in a patient. The child insists to sit upright, tripod position, chin thrust out, mouth open. They're positioning themselves in order to have better gas exchange, better airflow. If you aren't sure what tripoding is, just Google it and look at a couple pictures to get that straight in your mind. Helps with opening up the chest and with breathing. Nasal flaring is another thing. The little nostrils will go in and out as the child really works to get air in. Retractions, suprasternal, substernal, intercostal. That is the sucking in. It looks, again, if you've never seen it before, you're not familiar with it, Google it, watch a quick video. The skin looks like it's sucking in around the bones, really working hard in order to breathe, using accessory muscles, right, where they're not usually working hard to breathe would be another thing you could see. Pale skin color to cyanosis, depending on the degree of obstruction. Tachycardia as well. So if I'm not getting enough oxygen, the heart's going to beat faster to pump around what oxygen I do have. And the epiglottis itself appears edematous and cherry red. So it's swollen and cherry red. The cardinal signs you want to recognize, the 4 Ds here: drooling, dysphagia, dysphonia, distress respiratory efforts. So a lot of times we hear that like stridor is a big red flag. You need to know the patient's about to lose their airway. Don't forget that drooling is another one. We have so much swelling that they're not able to swallow their secretions as well. Dysphagia, difficulty swallowing, dysphonia, difficulty talking, and distress respiratory efforts. Complications, the big complication we're worried about is complete airway obstruction and, of course, acute respiratory distress. In terms of lab testing and diagnostics, the first thing we want to mention is we don't want to do a throat culture. So normally you have someone come in, we think they have strep, whatever it may be, and we get a little swab to get a sample and see what exactly is causing the problems for the patient. With epiglottitis, that throat culture is contraindicated. The concern is that you have so much swelling going on right now that if you were to put a swab in the back of the patient's throat and even gently get a little sample, that irritation could cause the swelling to increase just enough to actually cause a complete occlusion of the airway. So we're not going to worry about figuring out what the bug is, what the infection is at this point when the child is in distress. We're going to treat the child, and then later when we know the airway is secured, going to be patent, and their oxygenation status is okay, then we can move along and think about what might be causing this infection. Another lab we could look at is the white blood cell count, because that would be elevated as well with an infection. All right, priority problems for this patient is the risk for an occluded airway, impaired gas exchange, infection. Those are the things we're going to be prioritizing with their care. In terms of treatment, airways are a big priority, just like we've learned since day one, ABC. So maintaining the airway, child may need to be intubated, is the first thing we need to do. We're going to monitor the patient's oxygenation status, monitor ABGs. Once the airway secure, the patient's intubated, whatever the patient may need, we can then get throat and blood specimens to do a CNS, a culture and sensitivity, to figure out what bacteria might be causing the infection and what medicine we can best use to treat it. Antipyretics can be given for the fever, so medications to bring down the fever. Antibiotics are usually administered then to start attacking that bacterial infection. The biggest thing for us is we want to be monitoring the patient's respiratory status. ABCs, airway, breathing, are our priority. So always look for signs of respiratory distress. We talked about them already: stridor, nasal flaring, tachypnea, tachycardia, retractions, drooling, changes in the level of consciousness, cyanosis. Be watching for those, because that indicates that the patient's oxygenation needs aren't being met. A sudden decrease in respiratory effort could be a sign of exhaustion and impending respiratory arrest, so keep an eye out for that. Monitor your patient's ABGs. Make sure they have a patent airway. Make sure the oxygen is set at whatever they need to keep them within, 95 to 100, whatever the doctor has ordered for them. I'm looking here, see if there's anything else. Big thing just is to remember is they can progress really rapidly. So we want to keep an eye on the patient's status and be assessing them very frequently until we see that they are actually improving. And that is it for epiglottitis.